Interesting point. Ovarian cancers originates from the epithelial cells lining the surface of the ovary, lining the surface of the ovary in about 90% of cases. However, growing evidence, my beloved, suggests that many so-called ovarian cancers may actually begin in the fallopian tubes as serous tubal intraepithelial carcinomas, which later spread to the ovary and peritoneal surfaces. This shift in understanding is crucial. It means that disease often starts microscopically in areas that are very hard to detect through screening or imaging. Clinically, early stage ovarian cancer is notoriously difficult to diagnose because its symptoms are non-specific. So bloating, abdominal discomfort, airway satiety, or changes in urination or bowel habits. So these are often mistaken for gastrointestinal issues or hormonal changes. By the time symptoms are recognized, more than 70% of all patients are already stage 3 or 4 with widespread peritoneal involvement and metastasis. One of the most interesting and clinically relevant aspects is the role of BRCA1 and BRCA2, so-called mutations. These genetic mutations, let it be mutations, not only increase, it's a feature, it's not mutation, anyway. So these genetic mutations not only increase the lifetime risk of ovarian cancer up to 40-60%, but also have important implications for so-called targeted therapy. For example, PARP inhibitors, PARP inhibitors such as olaparib have really revolutionized treatment by exploiting the concept of so-called synthetic lethality, targeting the DNA pathway that BRCA mutated cells rely on, leading to so-called selective destruction. That's very okay, very good, it's great, but the price of these medications are extraordinary high, inexplicably high. Anyway, so diagnosis involves a combination of transvaginal ultrasound serum CA125 levels and imaging studies, but none of these are sensitive enough for effective population screening. That's why risk-reducing salping oophorectomy now is recommended for higher-risk women with BRCA mutations after childbearing is complete, so in menopause. Treatment generally includes cytoreductive surgery, so-called debulking, and platinum-based chemotherapy. Okay?